Good evening, everyone. Welcome to part 2 of our CET Approved Dry Eye webinar series with Dr. Kea Patel. Thank you very much to those who attended the last one. Pleased to see you back. And we look forward to obviously hearing part 2 with regards to obviously what we Dr. Patel's perspective on dry eye. Over to you, Kea.
Thanks, David. Good seeing everyone again. I hope you are seeing me, and I hope you're seeing a screen which says Altacore on it. If David could, can you just confirm that for me, David?
I can't see your screen at the moment.
Can't see, right. So let's hit that one. How about now? Oh, I totally disappeared.
Not yet. Keep saying waiting to view your screen.
So, give me 1 second. I've got the screens up here. I've just got to try and figure out why it is not wanting to share screens. I've got an idea. Let me do that. And give me a second just to do, just going to kick in a couple of, just made a couple of adjustments here. And do that there. And everything has disappeared. Sorry, give me 1 second. I apologize for this because today has not been my day for screens. Because I had an absolute mare with these. Everyone, view presenter. No. Oh, this is what happens when you try to be too clever and you try to go really complicated, and your wife's actually laughing at you at the number of screens that you have flying around. And it just means that you end up doing it. So, got that control panel, webcam, single screen. And I'm going to do that. I'm going to do share, play, slideshow in the video. How's that? David?
I still can't see anything, I'm afraid.
Oh, what's going on here? Why is it not working? And there? No. All right. I have no idea what is happening with this. View. No. Yeah, Oliver, if you could try sharing and just see what's happening here. Oh, I know why. David, have you made me a presenter, or am I still a panelist?
Yes. You're a presenter.
Yeah. So why is that?
Let me try again. Hang on.
There we go. I was on as a panelist, and that's why it had gone a bit funny. That's fine, excellent. So let's go show my main screen. And hopefully you guys can see something now.
Yeah,
we can see your desktop.
Fantastic.
Excellent.
Fantastic. Sorry about that. You don't even understand. It's been a day of it for me. So I'm just going to put this in the right place so that I can see what I need to do, and then we can go. Okay, so I'm going to quickly stop this because this has already started. We don't need to start it again. So welcome. Thank you guys for joining us again this evening. This is being brought to you by Altacore, who've kindly asked me to spread this out over 3 sessions to talk about dry eye, first 2 sessions. And the third session, we're going to do about developing specialty clinics, really using dry eye as the model clinic. for this thing. So this is the title slide. We did part 1 a couple of weeks ago for those of you who are nice enough to attend, and for those of you who are really bored, this is part 2. Can't see. Okay. So let me try doing. Oh, okay, I've got it. And there I am. Finally got to the slides. For those of you who were not part of part 1, or for those of you who don't know me, my name's Dr. K. Patel. I'm an optometrist, clinical director at Tomkins Knight & Son. Done a few bits and pieces, made my way here. If you really want to see the kind of imaging and stuff that I really enjoy doing, feel free to follow me on OptomaGeek, my Twitter and my Instagram. Just a few of the notices that I've done a bit of work for all of these guys, and I'm on the medical advisory board for AOS Sparker. And like I said earlier, when you didn't see the slide, today I've been kindly asked by the team at Altacor to speak to you guys and go from there. So to do this, I've been asked by Jane to make sure I get the housekeeping correct and in order. You need to answer 6 poll questions to get your CET. I think she said 6. No harm, they're not hard. I know it's early in the cycle, so most of you are probably not here to get points. I'm hoping you're here to learn stuff. So we're going to start off nice and easy. Poll 1, David. Who's back? That's a good number. It's a good mix. Glad to hear that. So we're going to go for the 63% of you who have returned. I'm actually going to roll straight into poll 2, please. And the question is, were any of you able to implement anything that I mentioned in part 1? Oh, 50%, I'll take that. So 30% approximately of the audience took away something from last time and went able to implement it. That's a start. I'll take that. Excellent. And without further ado, I'm really going to fly through the polls, get through as many of these quickly. We're going to go straight into poll 3, and that is for those returning. No, that's not the poll. Where's it gone? What treatments do you currently offer? So David got a different poll to me. Sure, we can answer that one instead. Well, after part 1, did anyone read IP? Okay, so about 20% of the people sitting here, of the people who were here at the time, were going through. This was a question that I put out for poll. I don't know, David, if you've got it, launch it. If not, don't worry about it. It's we can move on and we will come back to it. So I'll give David 30 seconds, see if he's got it. If not, doesn't matter. Or if you just give me a no, David, or something, then I'll just keep moving on. Okay, that's fine. Good. All right, so let's keep going. A quick review of what I went through last time. So in about 30 seconds, what we did was we ran through DUSE 1, DUSE 2 even. We went through definition, how to do treatment, diagnoses, and diagnosing tests that's required by DUSE 2 to give you a diagnosis, right, of dry eye disease. And then what we started to do was work on the management element of how you're going to do it. Once you've got a diagnosis, what you're going to do. And the summary slide that I finished on, you can read it there. You all have the tools. You know, you guys are best placed to educate the patients already and initiate the treatment. And you just got to keep up to date. And that's what you are doing by being here. And we appreciate that. So I ran through this beautiful diagram here, which breaks everything down, you know, step-by-step guide to getting a diagnosis. And we got to the point where we'd worked our way up to stage 1 of management. And, you know, the key point was education. You've got to give them the knowledge, okay? And then you've got hydration. We talk about, quite appropriate that I managed to pick Tom Brady, even before he got his 7, for those of you who like the American football. And we spoke about nutrition. You know, these key elements, I really would have hoped that everyone's talking about those anyway. Talking about nutrition, that got me thinking about a couple of my patients that I've had recently. And it's not just what people eat, it's how it affects their bodies and what's going on. And there's a lot, I think, to be said of gut health, you know, are people looking after stomachs? There is a correlation between people who have celiac disease and have these issues. And so when you're going through your questionnaires and things like that, it's almost worth asking if they are IBS, celiac, things like that. I've had a couple of patients who had real benefit, and this was before they'd come to see me. They'd taken on, they'd done the Google searching, and they'd really taken on getting rid of all inflammatory elements of their diet. I have a patient who is very, very dry eye, and he went and had allergy testing. He's allergic to pretty much everything, and has modified his diet to reduce his inflammatory load within the body. So it's worth thinking about. The conclusion of that particular study was that tear film function and conjunctival surface epithelial morphology was significantly altered in people with Crohn's disease. And so you want to think about that. And it's interesting, we come into the profession, we're all about eyes, but we are now having to become, with things like dry eye, a lot more holistic. You've got to be looking at the bigger picture. So interestingly enough, I've put that slide in twice. There we go. We'll skip past that and go to that one there when it finishes again. That's another 30 seconds for those of you who weren't able to see that. And we got to basic management. And basic management, these elements of management are all pretty straightforward, and you should be able to supply these. You know, they're a source of income, and they're not hard to do. They hopefully keep your patients coming back to you. So at that stage, essentially, what we had done was we'd covered education, environment, diet, lubrication, hygiene, warm compresses. And what we're going to do now is we're going to really step into what I would call the next level of management and start to introduce things that you can do more in-house and more in-house treatment. And I'm going to talk about them. There's no need to say such as. And at this stage, what I'm going to say is you might want to think, if you're going to start offering the higher element of dry eye management, you want to start thinking about the toys. And the reason I say it, interestingly, is because of something that I forgot when I was talking to the team who was here 2 weeks ago. Now, when you're doing the Juice 2 and you're doing the workup, there are actually a lot of steps. You know, to get all of this information and put it in one place, you know, it can be a little bit overwhelming, especially when you a little bit new. So you want to make the checklist, and the devices make it easy. The K5 one that we use in practice literally will walk you through it one by one, which makes it excellent. And then as you do it more, you will get muscle memory, and you will start doing things automatically, and you won't need those kind of things. But like I said, the thing that made me really think about it was I forgot to mention blinking. All right, it's one of the easiest things to fix and to educate your patient about incomplete blinks. And so you can see with this patient, 3/4 blinks, some not even a half. And you can educate your patient, and it just reminded me that sometimes it's nice to have a little bit of a guide to what you're doing. And this little, you know, when you grade it on this machine in particular, it lets you grade where you are, okay? Lid function and blink frequency, blink completeness. And they're good things to know, because if the issue is just that the patient is not blinking properly, that you can train them. And you can either train them by giving them the 30-30-30 rule that Brian likes to talk about, where every 30 minutes you do 30 hard blinks for 30 seconds, okay? And it's just like any kind of exercise routine. So to move on to more interesting treatment, I'd like to thank Brian for this image here. And for those of you who do a lot of this, for those of you who just like to check off the CET points, you'll probably, or I hope you'll recognize what that is. And I just want to throw this in there. And this is an electron microscope image of Demodex within the skin. Probably one of the grossest things I saw when I first saw it. I hope you guys have had, no one's eating their lunch or dinner even whilst at the screen. But that's what it looks like, and you can see the penetration. And that I got from Discover magazine. You can find them online. They have an Instagram, but that's a great thing there. And we hear about it a lot nowadays. And this is an electron microscope of a Demodex, really. And what do we know? And what we've been told is a management for Demodex, and that is tea tree, or to be specific, it's the terpinol. 4-ol within the tea tree that kills the Demodex. So what we do know is that there is an oil for that, okay? And in the good old days, bad old days, if you are some of my colleagues, what you had to do was you would take about 50% tea tree, you would mix it with another nut oil, macadamia or something, and then you would apply it to the lids, and you would cross your fingers, and you would hope that it didn't get onto the cornea, because as you know, cornea tea tree is toxic to the cornea. It can leave an almighty abrasion, which is not fun for the patient and not fun for the practitioner who's trying to manage it in thing. And then, you know, I'm happy to be corrected on this. Then Clearadex came about, firstly available in the US, and now commonly available in the UK. And it was first of a real generation of TT products and Demodex treating products that are available through multiple manufacturers. So interestingly, I'm planning this. I'm like, wait, I can talk about tea tree. I can get it done. No one needs to. We don't need to dwell on that too much. And then this article pops up. I think it was December. How terpinol in vitro will kill meibomian glands, or democidal, toxic to meibomian glands. So now you have to be thinking, right, if you're giving your patient tea tree treatment, you're going to have to watch their glands, because you want to make sure that the tea tree is not destroying their glands. But also you may have to be in a scenario where you're having them treat and then stop, rather than being constant treatment. Personally, I've not seen it. You know, when you read these studies and they talk about how these things work, you know, this is in vitro, so it's not in vivo. So there are tools there for you to monitor gland atrophy, but you're really going to want the toys to do that. So it's worth investing and speaking to the guys who can do it. So this is same image, courtesy of Brian, and we've just given it a bit of a clean with a spud and a bit of okra juice to clean it out, and that's what you get. And this is possible in practice. For those patients who are going to struggle with, you know, really ingrained blepharitis, this is how you've got to do it. You've got to do it in practice because they won't get it at home. It doesn't matter how much they try. And if you're doing it, you need to account for time. And there are some great tools available to do it. BlephX has been around for years. I think they have a version 2 out. Newer is this new LIDS device that you can actually take home and you can use it at home. But the real, you know, what you really need, only really need is a spud and a golf club spud. And once you've got your golf club spud, you apply what you need to do and you just scrape. It tickles, all right? And your patients may not love you for it, but it is effective. And if you're not at the stage where you want to invest in, you know, cleaning units, then this will work, and it's easy to do. So you've cleaned them up, all right? What else can you offer in practice? And in practice, a very, very easy option, which will differentiate you from a lot of your colleagues, is just using punctal plugs. Okay, they're not hard. They take a bit of practice. And Oliver was kind enough to remind me that the Alticor Lacrizol, you know, has 6 months. It's dissolvable, but it'll be in there for 6 months before it will go. They are an easy point of access. But if you are going to be thinking about doing tears, you also really want to be thinking about checking inflammation, and you want to be checking that there are no inflammatory markers, because you don't want it sitting there on the skin. Now, this is a video of me inserting an inner canalicular hydrogel plug by a manufacturer. I'm a bit shaky because it's my weak hand upper puncture, so I apologize for that. But you can see with even the amount of shaking and the fact that the high mag distorts it is what I'm going to say. I really wasn't shaking that much. It's just a magnification, obviously. How simple it is. And as with anything we do within the practice or within our premises or within our clinics, it comes with practice. It's not hard. It really, really isn't hard. And for those of you who are business owners, experiment on your staff with their consent, obviously. You know, it's easy to do. As well as what we tend to do in practice is if we feel someone is aqueous deficient, we'll put a temporary plug in first. The last thing you want to do is put in a permanent plug and then end up in a scenario where they're epiphora and you're then ending up trying to take out a plug. And they're easy, simple, entry-level in-house treatments. So what Dews talks about then and is something that you really want to think about, but is definitely a investment. It's an investment piece. Is intense pulse light. So there's a couple of devices. I can't remember if I said this last time, but I'm sorry, I just want to quickly reply to this. But I do tend to talk about the things that I have because I know about them, and it's easy for me to answer questions about them. The iLight we've had for a couple of years, and from our experience, it's been good. You know, it's as simple as that. My data, not someone else's data, not done anything else. We get about 80% success. The Luminis is a new device to the British market, been available in the US for quite some years. The nice thing about IPL is that it came from dermatology. And what it means is that it's a broad device to use. And if you're really kind of outrageous and you really want to be cutting edge, you can offer derma services as well. You know, you've got beauticians doing IPL for hair removal and things like that. And if you're prepared to get the training and the certification, I don't see why there's any reason why you shouldn't be able to offer additional treatments with your device, depending on which type device it is. So this is a nice video of me getting zapped. Don't know if you can hear that. Okay, so you can't hear it, but basically what is happening is that flash of light is preceded by three what essentially sounds like electricity. And if you get it too close, you feel it, and you have to let your patients know that it's not painful, but it's not painless. I don't know if that makes sense. And these are my images of a patient that we had who had IPL, and you can see those, lots of those small telangiectatic vessels, and you can do a whole lecture on IPL, but very, very basically, it flash eats small blood vessels, flash eats meibum. The flash eating of the small blood vessels reduces inflammatory materials leaking onto the lid margin, is what they believe. Flash heating the meibum speaks for itself. You can then express it better. It's got some complicated cellular level stimulation of mitochondria, and it treats dermatitis. So a good way, good treatment, and straightforward. You can train your technical team, your clinical assistants to do this treatment. It's really straightforward. And I just wanted to show you someone who'd had IPL and the effect it had on their tear breakup time. I know, I mean, pretty much speaks for itself. I don't need the bottom left is the first visit, and the middle is actually the third visit. And you can see that significant improvement in tear breakup time. Another thing you can do, and which is easy to do, is gland expression. Okay, it's fun for some people. For me, it's a little bit weird. But you just need the tools. And again, this is just a simple paddle. You can anesthetize if you wish to anesthetize. I usually don't. And then just give it a good squeeze and see what comes out, and go from there. You can run along the top lids as well. A bit harder the top lids, not as fun, but it can be done. And sometimes people need it. So I like this slide. This slide always makes me laugh. And whenever I think of this tool, I think of this, and it's LipiFlow. So LipiFlow is essentially, for those of you who do not know, you're warming up the gland or warming up the lid from the inside and out. Just going to quickly do that. I've managed to over jump it. I've hit the button. So the shield that you have there, white shield, sits like a scleral lens on the orbit, and the back of it warms up, and then the milker, I guess, sits on the front, warming it up from the front, and it's a milking system. And it's got great results, great data. People like it. It's very popular in the US. For some reason, never really took off here, probably because of the cost implication. It was at the time when it was first out, it was never the cheapest of devices. But since it's been rebranded and taken over by the pricing has come down, but it's something that's worth contemplating if you really want to do it seriously. Dry eye. And then this one is, I'm just going to throw it in there. It's a big one in the US at the moment. It's not really taken off here, and I don't know anyone here in optometry who's really doing it, and it's intraductal probing by the team led by Stephen Maskin in the US. And essentially, you take a probe and you feed it through the gland orifice, and what their group are saying is that it can show regeneration of glands. It just helps unblock them essentially and get functioning again. And it's interesting. It's supposed to be quite painful. I know a couple of people that have had it done, but it's interesting to see if it takes off in the UK. Maybe a few more years, I think, before we get comfortable doing it. So I've gone through a lot really quite quickly, and what I didn't say at the beginning, I probably should have. What we want to do is, if you have questions, feel free to ask. I have David sitting there who's happy to screen them. So if you have any questions about anything that I've covered so far, I realize I'm going at a rate of knots, and 35 minutes in, and I'm not halfway, but I'm almost there. And so this is, I'll give you a minute or two if anyone has anything that they'd like to ask about anything that I've covered today, and then we'll keep going, really, and we can keep going. That's all. Have a sip of water. Keep the hydration up. Anything, David? Anyone interested in throwing a question at me?
Yeah, there's one question on the chat for you, Kaya.
Okay, let's have a look. What I'm going to ask you guys, if you put the questions in the question box, it just makes it easy. I'm just going to find the chat. Where's the best place to buy a paddle expression? I was actually just looking for that. I have a feeling, if I remember correctly, that Kestrel do it. Kestrel have them. I don't know, to be honest, because we've had ours for a while, so I've not had to get any new ones. And we're lucky, we have a dentist above us, so they just autoclave everything. So we make sure we get stuff autoclaved and cleaned. So I'm pretty sure Kestrel do stuff, but if you just Google it, I know it's a bit of a cheat of an answer, but you just do it. Another question that we have is, what is our protocol for IPL? So we developed our protocol guided by what Topcon, who is a distributor in the UK, told us. So we will have a dry eye assessment. So we have a complete assessment appointment, and at that point we will talk about IPL if we think it will be beneficial, and we will go with either 3 or 4 courses, 3 or 4 treatments split about 2 weeks, and go from there. And every assessment we will do OSDI screening, and sometimes we will do gland expression as well a lot of the time, and we might do tear breakup. Interesting thing about IPL is that if you generate business for private cataract surgeons, it's really taking off in the private cataract market, in that they like their patients to have the best tear film possible. And so we find that a lot of our patients who we send for cataract surgery, we have the surgeon saying, can you please give them a course of IPL first to make sure that their tears are as optimal as possible, especially for those guys who will be investing in premium lenses, multifocal lenses, and things like that. How do you go about telling people that they have Demodex without them freaking out? Freaking out is what makes them have the treatment, really. I don't think, from out, you can laugh about it. It's funny. I think it's funny if they freak out, but you just have to keep you can have a laugh with them as well, but you just explain that these are natural, this is natural flora that is on your face, on your body, anyway. It's just the colonies have got to a stage where your body can't manage them. And when you're at that stage, they need to be treated. And that is how you treat it. And you're the person who's going to treat it for them. And you're going to fix it. And you show them a before and you show them an after, and they love you, and they will come back to you. But you want to be the first person to tell them that they've got Demodex. The number of patients, or even blepharitis, the number of patients we've seen who come in and go, no one has ever told me that or shown me that before. And I know patients can be a little bit, they don't remember when they've been told stuff, but you want to be the first person, because if you're the first person, they're never going anywhere else. And I can tell you that. If doing IPL, do you still recommend a patient? Yes. So if you're doing IPL, and I'm not sure if the person who asked that question was in the first lecture last week. This is a stage management strategy. Okay, so it's like saying, if they have IPL, do they stop having to hydrate, or do they stop having to eat properly? It doesn't work like that. Okay, this is stage management. Yes, you work your way up that management tree. So they've still got to eat properly. They've still got to hydrate. They've still got to do lid hygiene. They've still got to manage all of that. IPL is just another treatment. And IPL, like everything else, is not a magic pill. It's not the golden bullet. It works. You kind of have to do a repeat top-up. You do top-up treatments. I have IPL once a year now, and it keeps me going. Keeps me really functioning. I really like it. I'm a big advocate for IPL. Do you need to be certified to do these techniques? You have to be trained, but I don't think there's any real certification. As far as I know, I've not looked into it. I will be 100% honest. And I'm sure if there's someone on here who is from college or AOP, they would pull me up on it. But as far as I'm aware, you don't have to be certified to do it. Do you use any NMP9 devices? We don't have any devices. The closest thing we have is Inflammadry, which I guess is a device. That's what we use. It's the only one that I know of that's available in the UK at the moment, although I hear rumors of, but have been hearing for a while, that TLab are going to incorporate MMP9 into their chips in the future. What's your favorite go-to product when treating blepharitis and cleaning lids? Zoccular is my favorite at the moment. Stuff's amazing. Works a treat. It's what I actually used in that demonstration. Pretty nice stuff. You know, patients love it. It doesn't sting like the Demodex, and it will dissolve those crusts. It will really expose those housing. Does IPL help with my bum damage by Roaccutane? So that's a tough one. Roaccutane is some of the most awful stuff for meibomian glands. It absolutely destroys them. Had a couple of patients, actually I've had one patient who had Roaccutane, didn't really notice anything else, was just like, oh. But Roaccutane, I mean, it makes me sad when people have to go on Roaccutane, because that stuff is pretty gruesome stuff, I think. And it can, you know, the short-term gain of Roaccutane and skin can really put people in life-changing and, you know, really mess with people in terms of just their mental well-being. You have to really be careful with it. In my very limited experience, I should say that. So another slide, no more questions, so I'm going to keep going. Another slide that I borrowed from TFOS Juice 2. And it basically just shows the cycle of inflammatory cycle of dry eye. And let's go to there and go there, and let's go to that one, and it's just done something funny, so I'm just going to click that button there. And dry eye is a self-perpetuating inflammatory cycle, and if you don't, you have to somehow figure out how you're going to break that cycle. Okay, how do you manage inflammation? And this comes back to the MMP9 question that one of you lovely guys asked about earlier. Is how do you know you know, eyes get red, you know something's not right, but the tools that are available now, for us, we use the Inflamadry kit it's now by Quidel. It used to be by another company. And like I was saying, that looks like someone else will get onto that market. The other thing you want to be looking at is osmolarity, okay, as a bearing on it. And again, this is a slight repeat of last time, but you're not going to know if someone has inflammation and high osmolarity tears if you're not measuring it. The two devices there are iPen on the left and Tearlab on the right. So if you're not prescribing it, you know, this is not the time where I say, okay, you can switch off. I think there are a couple of options that are available and that are very, very good. And for those of you who kind of follow the journals a little bit, you may know about Optimal or Manuka honey and its benefits. So interestingly, I was talking about it, and we at the practice have used Optimal for at least 2 years, if not 3 years. I saw a paper by a colleague who actually someone I know who I referred to, and they mentioned about it. Brian has many colleagues in New Zealand and Australia who have been using this for years. And interestingly, we just got this paper came out in October of 2020, talking about Manuka honey, and you know, is effective at reducing tear film evaporation after 28 days. And then another paper came out, funnily enough, and this one I don't even think it's been published yet, pre-publication. Oh no, January, sorry. And significant improvement in symptoms and objective signs in meibomian gland dysfunction. Manuka honey has been known for a while, it's got natural anti-inflammatory, antibiotic properties, and you know, it's available in the UK. There are people out there who supply it. It is over the counter. People like it. You know, you'd be surprised. You know, we're a world where we're trying to head back towards organic and what's the word I'm looking for? Homeopathic, Ayurvedic for the Indians in the audience. You know, all these options that are available that are not produced chemically, and it's out there, and it's definitely worth a try. I think we have 10 members we have 10 members of staff. At least 5 use Manuka honey regularly, me included, for dry eye management. It's good stuff, but boy, stings. Absolute. It's yeah. Just make your patient aware. So I'm going to fly through this poll question because David's already asked it. He jumped the gun. And we know that for some people it did, for some people it didn't. And for those oh, there we go, there's the results, thank you. For most people it didn't, and for some people it did. For the 63% who were not considering IPL, IP even, time to go. You're gonna find the next bit boring. I joke. You can't do it. But I feel that I should mention the college's course. And if you go to their website, I'm a fellow of the college, but I don't do anything for them. Beyond that, there are the courses that are available. When I last did screen grabs, that's how you do it, and that's how you get qualified. Okay, you sit a common final entrance exam at the end of it, and lovely day out with the wife, collect a certificate, and do more for your patients in practice, and give them more reason to want to come see you, and give you less reason to have to refer them. So at that point in stage of management, I would say that if you are at that stage, then you are going to start hitting the drugs pretty often. A couple of questions that have just popped up in the last minute. I'm just going to answer those. Are you slow to recommend tea tree containing oils long-term for maintenance given the query over MGD? The query over MGD only came up a couple of months ago. So no, I mean, we probably don't use it for maintenance anyway. We probably try and get them clean and then get them onto regular, something more regular, something more generic. We have a couple of patients who've used it routine, and what for me is going to change, like I was saying, I'm going to image their glands more, because if there's any kind of changes within their glands, then we will know, you know, it will show it. How do you use Manuka honey? You buy drops or you buy the gel and you read the instructions. You don't do what I did, which was a bit silly. You don't, well, I didn't do this. So firstly, don't go and buy it off the shelf, okay? There are formulated ophthalmic formulations. So what happened with me was I was using the drops, and the drops are great. There's essentially diluted Manuka, and you just put the drops in like anything else. So what I do is I put a drop in, because it stings like almighty. I keep my eyes closed, and then anything that comes out, I rub into my lid margin. So it helps keep my lids clean. So what happened is it also comes in a gel formulation, all right? And so that's pure Manuka in a tube that's about this big. And I didn't read the instructions. I went, oh, this must be a thicker version. So I've put like a ribbon of Manuka honey into my eye in practice, and I can tell you it's smart like almighty. It is, yeah, I won't do that again. With the gel, you take a small pin, you know, like a match head size, and you just rub it into the lid margins. Are these polls only for people who did part one? No, there are polls for everyone. It was just a case of I wanted to see if I'd managed to persuade anyone from part one to take IP who hadn't done it. Which supplier can we obtain Optimal from, please? If you guys message me later privately, I will do that, because it's not fair on Altacore, who are being nice enough to ask me to talk about it. As an optometrist, do I really need to re-qualify as an IP? Well, that's a long question. You don't have to re-qualify as an IP. If you want to be the best optom you can, this is my opinion. This is not necessarily Altacore's opinion. This is not anyone else's opinion. This is my opinion. If you want to be the best optom, you should get IP. If you want to manage your contact lens patients to as far as you can, you need IP. If you want to do dry eye, you need IP. If you want to manage your allergic conjunctivitis patients, you need IP. Otherwise, you're just going to end up referring all these people. You know, what's the fun in that? You know, that's what I was doing 20 years ago. And your patients will just look at you as someone who detects stuff, and you won't be that person who can manage it. So I'm quite passionate about IP, and I do get on my, you know, I do get on my soapbox about IP, and I do think that you should leave university with IP. Do you need it? No. Do you want to be the best optom you can? Then yes, my opinion. And if I've offended anyone by saying that, I apologize, but that is what it is. So we then go into the realms of steroids. Okay, so what do steroids do? All right, that's all for the question. Sorry. Oh no, one more. Follow on from Manuka honey question is it better to use Blephademodex? Blephademodex is a different product. You know, Blephademodex is a white with tea tree in it. I've not seen any studies, and I've not seen myself how Manuka will deal with the casing along the lid margin that the Blephademodex gets rid of. I've seen some anecdotal stuff, I think, about Manuka honey and Demodex, but nothing major. So I don't know. I'll be honest with you on that. So we get onto steroids. What do steroids do? They suppress MMP9. They help cytokine expression or suppressed cytokine expression, and they're mechanical. What do? You have a couple of options in the entry level stuff, and those the two that are really pushed and promoted are Lotemax and FML, because they have low penetration and they work really well. Personally, my drop of choice is FML. For some reason, Lotemax always seems to be hard to find, and I'm always hearing that Lotemax stings more. I've not had to use either of them personally, but FML tends to be my drop of choice. There's lower risk of complications. For those of you who haven't had to pick up a pharmacology book for a while, you hear steroid and you're always thinking, oh my God, there's going to be IOP spike. Oh my God, the cataracts. With these, there's lower risk of that happening. I'm not going to tell you it doesn't happen, but that's why you have IP. You give them the steroid, and if their pressure goes up, you manage the pressure. They need the steroid for a reason, and it works. And more recently, you have preservative-free version, Sofocol, which is hydrocortisone. Again, lower penetration and stuff like that. And you can pulse steroids, and there are a couple of people who will literally go off of the steroid, be good for a bit, and then you have to give them a week's course, 2 weeks course, and they'll go off it, and then they'll come back. These guys you want to have on plan, you want them on long-term management. For people who tend to need long-term steroids, and steroids are working for them, the option then is to go into cyclosporine. And this is a non-steroidal immunomodulator with anti-inflammatory properties. Okay, it says what it does on the tin. It's anti-cancer drug is where they found it out from. And at the moment in the UK, the only one that I can think of that's available is Icavis. And you to get a patient onto this, they've got to have tried everything else. This stuff runs at 90 quid a month. Last time I checked, £100 a month. So it can be quite expensive. But for the people that it works with, it is amazing. It works really. It's game changing. You'll hear about the Americans. You go on any of the forums. The Americans love cyclosporins. They talk about Restasis all the time, and it works really well. So what you want to think about with the cyclosporins, and what you need to bear in mind is it's not good for post-surgicals. It's not good for the contact lens associated either. And there's only about 50% success. So you'll find that a lot of hospital units are very reluctant, I would say, to go down this route unless you're in a specialist clinic. If they've gone to the general clinic, they're not going to get it. What I did once, had a patient who was at the end of her tether, really. She tried everything. The only thing that would calm her down was a steroid. So I wrote her a private script, and she went for cyclosporin, because she went and paid for it. She'd had enough. She was like, I'll pay for it. And it worked, and she was really happy. And so what then I do is I write a really, really nice letter to the GP, and said, look, we have done blah, 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 blah. The only thing, she's still doing this. The only thing that really giving her is benefit is the cyclosporin. And I said I was happy to manage her. GP went fine, signed off on it. And that lady's very lucky to have such a understanding GP who's prepared to do that for her. Quick question: how long do you use FML for? You probably want to go for about 4 weeks, really, with a pressure check at about 2. I normally go about 3 times a day and check them at 2, see how they're getting on. But it takes, all of these things take a bit of time. And like I said, and I'll probably keep repeating, is that this treatment doesn't mean you stop the other treatment. You still do the lid hygiene, you still do the warm compresses, you still do the artificial tears. you just do it. Once you've stepped past the topical, you end up in the realms of oral. Okay, and the two real big ones. You've got the tetracycline, which essentially helps soften up they change the formulation. I don't know how it works. I'm not going to pretend I know how it works. But it changes the formulation of the meibum, helps it express better. It seems to have anti-inflammatory properties. And depending on who you follow, what you like, there's variable dosing strategies for it. Personally, I'm a fan of azithromycin, which is a macrolide. Similar endpoint, okay, without going into the science of it, the endpoint is similar, but the dosing is a lot better, in my opinion. You pulse it over 3 courses, and it's 3 days. So you do 3 days of 250 milligrams twice a day. Do it for 3 days, take a week off. Do it for 3 days, take a week off. Do it for 3 days, take a week off. Whereas with the doxy and the tetracycline, you're looking at 1 to 3 months, up to 3 months of 50 milligrams or 100 milligrams of doxycycline, which is, if you remember what I said earlier about stomach health and how people do with, how their gut reacts, right? If you're pumping them with that much antibiotic, not because it's an antibiotic at that, it's because of the other effects of it. You are gonna you're gonna find that it just doesn't make sense to have them on a long-term antibiotic, in my mind. Okay. Is IP prescription more expensive than the NHS prescription? Sometimes. Depends what the medicine is. If in allergy season, I prescribe Opatanol like it's going out of fashion, because why wouldn't I? It's a combo. It does both things. You get long-term satisfaction and immediate relief, and in doing so, your patient thinks you're the best thing ever, right? And it's not that much more expensive than a private prescription. If you do something like Ikavis, then yeah, it's gonna be more expensive because it's just an expensive drug. Okay. What about topical anti-infectives such as tetra versus oral? I think so. There's a question about topical antibiotics. I think where we're trying to go is, if I've read this question correctly, Oliver, I think you're talking about topical azithromycin rather than oral. It seems to have good effect, but in my mind, you're not really going to get the penetration if you use topical. So yeah, Azita, which is topical as azithro, versus oral, but you're not going to get the penetration. So you'll get good if you've got mild anterior blepharitis. You're going to get good penetration there, but for the really ingrained MGD, you're not gonna get in there, right? So how do you get in there? And with that, if I hit that button, we've covered stage 1 and 2. The next couple I'm going to fly through really, and I promise, we've only got a few left, and I realize I'm looking at the time and I've basically been talking like myself. So quick poll, give everyone a break, have a glass of water. Who fits contact lenses? Excellent. So the majority of you are contact lens fitted, or have the ability to fit a contact lens. Actually, that makes me curious about the 12% who do not fit. Oh, it may be some of the, we do have, I believe we have some dispensing opticians within the audience who may not. So you fit contact lenses, and that leads me on to poll 6 ever so quickly, which is for those of you who are fitting contact lenses, what do you fit? And I'll lie, I know I kind of fixed that question a little bit. I was just, this is more curiosity on my part. And that I find really, I find that really encouraging that 50% of you can fit whatever you want. It's a shame about the 22% and the 26% who have some limited, well, 26% who are limited by third party. But what you really want to do, hopefully, when you see the next couple of slides, is hopefully that will kind of inspire you to speak a little bit more and get your management on board with different products. And for those of you who get it, that's Iron Man. And we're going to talk about the irony of contact lens coming in so high in the management schemes. If you remember this slide, which I use a lot, contact lens is considered a risk factor for dry eye disease. And for those of you who are at least as old as me, this will hopefully ring a bell. But they've got to make their mind up. Where does this come from? So you've got contact lenses, run-of-the-mill contact lenses, newer designs. Are they therapeutic? Do you need to go, when we talk about using contact lenses, do you need to go to this level of fitting to get what you need? What we do know now is that oxygen is not an issue. I mean, the lenses, pretty much lenses, O2 is not an issue. What the big issue is surface quality, okay? You want to know how good it is, and that has a huge effect and a huge bearing when you're fitting contact lenses for dry eye. Because what you're doing, the aim of the contact lens is to act like a bandage. That's all you're doing. You're bandaging that cornea so that they are not getting exposure. And now with the new materials that are available, I love this slide. I made this a while ago, and I think it is a perfect example of where we've come with regards to lubricity. And you can just see the difference that these lenses make. So, this slide is, I want to run that one while I talk. The two products that I showed, one of them is a silicone hydrogel, one of them is just a hydrogel. But the manufacturers put so much emphasis into the quality of the coating of the lens that we've used it for patients who have come in with dry eye problems. We have one patient who was referred to us by, was referred to us by a consultant at the hospital going, can you fit this patient with scleral lenses? And we kind of looked at her and everything was fine. We went, well, why don't we try one of these first? And we went with one of those brands, happy as, doing well. Some of these new products are really good. So if you have a contact lens patient and they're like, oh, they're really dry, if they really want to wear contact lenses and, think about upgrading them. And you have to tell them why they need to be upgrading. Sorry, so there's a question. Let's just do this. This question is, would the same RX from the GP would be cheaper? Can we ask the GP to write an RX for the same RX? Yeah, you can. I mean, that's what we've been doing for a long time. But what you will find, and actually I don't know, they all depend on where you are based. Some GPs that will not. For example, I had a GP who I can prescribe steroids, and the patient didn't want to pay for the steroids and wanted his GP to do it. I wrote to the GP. GP went, "Oh, we've been told we're not allowed to prescribe steroids, have to go through the hospital." So you just have to deal with that, and you have to deal with the to and fro. And it is an absolute pain in the arse of the patient. And more often than not, you just say to them, "I'm going to give you this, go pay for it and do it yourself. It'll save you a trip, it'll save you 2 hours." You know, during COVID, they'll be lucky if they can see their GP, to be honest. Don't underestimate what patient will pay for the sake of convenience. Going back to materials, Contamac make this amazing material called, Contamac, it can be applied to Contamac. It's by Tangible Science, it's called Hydropeg. It's like amazing, super slippy. It is what we just saw on the right of that previous image. They're now going to bring it in to some of their newer materials built in. This is Optimum that's coming through. But contact lenses as a management option is there, you know. And if you can fit a contact lens, like the majority of you guys can, think of that as an option for your patients. If they're already wearing a contact lens, look at what they're wearing, okay? So we're flying now. We're almost done. We're at the top of that tree, and then I realized that this has really gone on a bit longer than I was expecting. All secretagogues is what they talk about next, and pilocarpine and cevimeline. Do I do it? No. Comfort zone, just a bit beyond it. It doesn't only really work for Sjögren's patients, and we don't have any, so I don't really do it. It's an antimuscarinic, and it seems to work better for oral dryness and ocular dryness anyway, from what I've read. So I don't. So this particular slide is for Kripa, who reached out to me last week. So I had to go on. Thanks. And the dosing on it. So pilocarpine is 5 milligrams a day, 4 times a day. The cevimeline must be a US or non-UK product. I couldn't find it in the BNF, but from what I could find, it was 15 or 30 milligrams a day. Where's he going with this? It's getting a bit late. It's hungry, and he's showing me the kernel. Autologous serums. So what it basically, autologous serum is basically that yellowy stuff that gets left when you have a scab. Is that too graphic this time of evening? I don't know. It's the gooey, sticky stuff, right? But it is really similar to human tears, okay? And it works really well for some people, okay? I'm not going to read the slide. You guys can read that. But it's difficult to produce. You need serological testing, and it has to be made in special settings. You then have to store it, and the cost of it is expensive. You can get it through the NHS. Now, I was talking to a consultant. Actually, I asked a consultant because a patient asked me. Most hospital services have access to it now, if the patient's there. But I've got a feeling the only way you're getting your hands on that is through the hospital. There are a couple of private clinics. I know a couple of patients who fly out to Portugal to get it privately from a consultant out there who makes it for them. The other option is allogenic, where they just take previously stored blood. But the issue with that is there's limited clinical data. And with that, we are at stage 3, and then we go into stage 4. Okay, so again, I realize I'm really showing my age with some of these slides. For those of you who don't know, that's the Incredible Hulk TV show, and long-term steroids. Okay, and I was really happy to found this. It's really quite good. You know, you just got to think about the risk benefit. Okay, if patients need long-term steroid to get through life on a day-to-day basis, and some of the really dry eye patients do, you just got to have a look at the risk benefit. Okay, and if you have to manage their pressure as well, If you have to keep an eye out on the cataract, you probably want to stay away from the PREDs and the dexamethasone to reduce the risk, but some people need it, okay? Now, you may get to a point where you, at some point along this lecture, you're going to get to your comfort zone. For me, it is still oral Pilo. I don't know why in my head. I've never done it. I would probably quite happily do it under supervision, but I've just not got there. And you've got to work to your comfort zone. And then you go on to some of the other more novel, newer treatments, and this GIF just makes me laugh. So amniotic membrane. Okay, so for those of you who don't know, an amniotic membrane is the innermost layer of the placenta. But again, I'm not going into how it works because that's lectures and lectures on itself. But stuff's like magic, right? It just helps heal things. And I believe at the moment in the UK, there is a study on amniotic membranes and its benefit to dry eye. Our colleagues in the US love this stuff. And they use it quite a lot. They're big proponents of using it. And I tried a couple of years ago. I had a patient with recurrent corneal erosion, and we tried to get an amniotic membrane, and we were told that we couldn't have it because we didn't have a tissue bank storage. But I've heard there are ways around that now through different suppliers who can provide you the membrane on the day you need it, and so you don't actually have to store it. And they're essentially like contact lenses, depending on which product you go for, which brand you go for. They fit onto the eye, and then you just leave them there until they go. And then all this goodness that comes out of the placenta, like stem cells and things like that, basically helps the cornea regenerate. The thinking is that it helps with corneal nerve regeneration. Oh, there we go. I'll say that. Therapeutic bandage. Oh, I've gone back. Missed it. Too many button presses. There we go. There it is. Controls ocular inflammation, regeneration of corneal nerve. Okay, but there's a UK study at the moment. One of my patients used to get themselves onto that. And then we talk about lid laxity, and I showed you this for the guys who were able to stick around for the first one, and I showed you this study, and lower lid laxity correlates with symptoms of dry eye disease. But then to fix that, you're really heading into the realms of surgery and heading into the realms of referral. And these are all the different types of surgery you can have, okay? But when you're here, I mean, unless you're really good, you're not doing this in optometry practice. But you need to know what the next stage is. You need to educate your patient about what comes next when you've done everything that you can do. And with that, we have ticked all the boxes. Ever so quickly, with regards to that, what the module doesn't really talk about and doesn't really go into is neuropathic pain. And how can you test for that? So one of the things that we used to hear about is something called the proparacaine test. And what you do is you take a drop of proxy and you pop it onto the cornea. If the pain disappears, then you know it's peripheral pain. If it doesn't disappear, it's central pain. And you would hope that it'd be really simple, it'd be as simple as that. But there always is a but. That I've overshot it. Go forward again. But one more. There we go. What they found was that it actually struggled to differentiate between the people who have proper dry eye disease and people who have neuropathic pain. So just be a little bit careful with the test. The real way, the gold standard way of checking if someone has corneal nerve damage is confocal microscopy, and that needs to go to a specialist center. There are a few around the country, a few people who specialize in it, and they can look and tell you if the nerves are knackered or not. And those guys really are looking at pain management clinics. And again, beyond my scope, theoretically, I could do pain management up to a certain extent, stopping short of narcotics. But at this level, you're looking at sending these patients out to someone else. And the reason I say that is because if they've got pain management issues, usually in my experience, they need someone to talk to. And they just tend to have other underlying issues as well to do with how they're coping with life. Stress-related PTSD is one that we've seen, and we can laugh at it with Dr. Lecter there, but there are they really struggle in life, really struggle in life, some of these guys. So I want to go out on a bit of a high and just give you a few pointers on what to look out for these guys. And you won't have been the first person they will have seen. Okay, they've also already been to the eye clinic. I say potentially very well informed because sometimes they are, and sometimes it's just Google crazy. They spend a lot of time on the internet talking to other people, and they will take up a lot of your time. So you want to bear that in mind. You want a separate email address for your dry eye patients. You don't want them coming into your regular email address. Otherwise, you will be doing emails at all times of the night. Just try to keep them done. And going to hit you with a summary, and obviously, again, this is all down to you. Dry eye disease is possible. Advanced dry eye disease is possible, and what you do is going to be dependent on where you invest, how you invest. And I'm not just talking costs in machinery. I'm talking about in terms of your education and further skill set. Like I said, I do go on about it. If you want to offer everything, you need IP, okay? And it can get very complicated. It can get very complicated. So I believe this is my last poll. Yes, again. If you don't want to do IP, then it's worth getting someone into the practice who can do IP for you and manage these patients. And David, who is my fantastic helper today, can help you with that. There we go, David. You should be getting some phone calls, mate, at the end of this. Good. I'm really glad for the guys who I've helped change their mind. I'm really glad. It's well worth it. Really worth it. And with that, I the future is yours. We're counting on you to do that. And we will go to there. Any questions, David, at this point?
We've got one more poll here.
Yeah, there any questions at this moment before I hit the poll?
Just let me have a look.
Can an IP Optom use a sign order instead of a private pad RX? Private pad order to RX? I don't see why not. Why would you? I mean, what I did was I just made my own private pad when I first started because I couldn't get an NHS one, and it's just a lot more convenient. You just need a format that the pharmacist will recognize, and so that's something that you can keep a record of what you've prescribed for the patient. But you know, if I'm really snobby about it and I'm totally on my horse, you know, signed order. Why would you do a signed order when you can have a prescription? Have I got my pad here? I don't know if I bought my pad. I just basically took a FP10 and reformatted it to make it look with my name and everything that I needed. It's just like, right, so bad. Just invest in a private pad, just make one with a carbon. Then you've got a copy, they've got a copy, and one's going to the record, especially if you are a locum and you want to keep a copy of what you're doing outside of what you're doing. Last poll, Dave. While people are doing that, I'll answer this question. Would you give a steroid on a decreasing dosage, i.e. QDS, TDS, BDS, tapered? Yeah, usually I do. I'm a fan of tapering, so I will, but I probably wouldn't do it that slow. I'd probably go 4 times, twice a day, once a day. Like I said, with the mild steroids, there's not really rebound, so I wouldn't do that. Can we have an NHS pad as IP? You can, if you can persuade your local commissioners to give you one. There's a lot of work involved. It involves having to get a budget and things like that. And I have tried in the past and I found it a bit too much, like hard work, in totally honesty. I just write private scripts. I mean, it works. Fantastic. 93%. I look forward to seeing the 93% of you in 2 weeks' time. To the 7% who will not be joining us, I wish you well. And with that, we have ticked 2 boxes out of the 3, and we head into February the 25th. Same place. David will be sending you guys reminders and I think some questionnaires and things like that. I have been Dr. Kate Patel, and I've been very proud to talk to Alticor. There's my email, there's my Instagram, and there's my website for prescribing type people. Even if you can't prescribe, I tend to put cases on there to share with people, and you can put your own cases on there if you want opinion. And these are the guys who have made it possible. So Alticor, reach out to them. They've got really good range of products, and from dry eye drops to heat masks to plugs, and take advantage of getting in touch with these guys to see what they can offer you and help you build your practices and dry eye services. And with that, that is it. So,
thank you very much, Kate.
You're welcome.
Much appreciated. Thank you to everybody else that attended today. Hope you've enjoyed the content and the engagement. Certainly find it fascinating. The final part is in 2 weeks, and we'll be sending out an email to everybody tomorrow, just with the link provided so that you can all register for the final part 3. If there's nothing further, we wish you all obviously have a good evening, and we look forward to seeing you all in 2 weeks' time.
Take care, everyone. Be safe.